Yeah. So I'll be talking about the pooled analysis of outcomes with second course pembrolizumab across 5 phase 3 studies of non-small cell lung cancer. I think logically it sounds when somebody is responding to immune checkpoint inhibitors, will it work beyond progression, or when we stop it, can we re-challenge it? But that obviously need a data backup when we are going through the differences between different ICIs and their mechanism of action and learning about their resistance also. So pembrolizumab as monotherapy and in combination with chemotherapy, it substantially prolongs OS and PFS as compared with chemotherapy alone in patients with advanced or metastatic non-small cell lung cancer without a driver mutation, we all know. And generally, immunotherapy is given for 35 cycles or 2 years in case of a continued disease response. Can IO be re-challenged after initial response or in case of progression beyond 2 years? We don't know, but logically it sounds. And in various clinical trial settings, patients whose disease progressed after completing 35 cycles, that is 2 years of pembrolizumab, they were eligible to receive a second course of pembrolizumab. So this analysis pooled patients with advanced or metastatic non-small cell lung cancer treated with pembrolizumab monotherapy, which was concluded as cohort 1, and patients were extrapolated from Keynote 024, Keynote 042, and Keynote 598 studies. And second cohort included pembrolizumab plus chemotherapy from Keynote 189 and 407 studies. So patients included in this analysis, they received second course pembrolizumab, that is up to 17 cycles, following progressive disease after either completing 35 cycles of pembrolizumab with or without chemotherapy, or with stable disease or better, or stopping pembrolizumab before 35 due to CR. So efficacy was analyzed in the intention to treat population and safety in as treated population. So if we see the results in cohort 1, that is pembro monotherapy, among 148 patients who completed 35 cycles of pembro and experienced a progressive disease after that, 58 received second course pembro. So it was an abstract presentation, so no full details available why remaining could not receive it, whether it was performance status, whether it was resistance, whether it was other reasons, and they were included in this analysis. So cohort 2 included 16 out of 55 who completed 35 cycles of pembro, who received pembro plus chemotherapy as initial, and they experienced progressive disease and received second course of immune checkpoint inhibitors. Then 18 out of 58 patients, that is 31% in cohort 1, which was pembro monotherapy, and 7 out of 16, that is 44% in cohort 2, had squamous histology. So 47 out of 58, that is 81%, and 7 out of 16, that is 44% respectively, they had a TPS of 50%. So median time from stopping first course pembrolizumab to starting the second course was approximately 11.7 months. So ranging from 3.8 months till 35.6 months in cohort 1, that is pembro monotherapy, and 6.3 months ranging from 0.9 months to 18.2 months in cohort 2, that is pembro plus chemo. Median duration on second course was approximately 8.3 months in cohort 1 and 7.6 months in cohort 2, with an estimated 62% and 59% respectively, remaining on second course at the end of 6 months. So median duration of response was at least 6 months. Overall response rate by investigator review during second course pembro was 19% in cohort 1 and 6% in cohort 2. And 14 patients, that is 24% in cohort 1 and 25% in cohort 2, they experienced treatment-related adverse events on or after second course, of which 3, that is 5%, and 1, that is 6%, were grade 3 and 4 respectively, and none was grade 5. So this is a tabulated form of the results what we discussed. Median overall survival in cohort 1, that is pembro monotherapy, second pembro re-challenge was 27.5 months. And in cohort 2, that is pembro plus chemo, it was not reached. 6 months overall survival rate was 85% in pembro monotherapy and 86.2% in pembro plus chemo. Median PFS was 8.2 months and 7.7 in the pembro plus chemo. 6 months PFS rate was 59.6% in the pembro mono versus 58.3% in the pembro chemo arm. And overall response rate was 19% in the pembro mono and 6.3% in pembro plus chemo arm. So this pooled analysis concluded that a second course of pembrolizumab monotherapy was feasible, at least, associated with anti-tumor activity and clinically meaningful benefit with manageable safety in patients with advanced or metastatic non-small cell lung cancer who experienced the progressive disease after completing the first course pembro with or without chemotherapy. So these data support pembro retreatment upon progression. So if we summarize all these things, so all other data which are available, say for Nivo also, they conclude that immune checkpoint inhibitor free interval is probably seen to be a predictive factor for PFS. For most patients who have experienced progression after ICI, chemotherapy is generally preferred because we do not know whether it is resistance or what exactly is driving the progression after ICI response. However, if progression occurs at least 6 months after, the last dose of ICI rechallenge can be still attempted. Trials with Nivo rechallenge also have shown overall response rate of 8.5% and median PFS of 2.6 months. So ICI-free interval was the only predictive factor of PFS, while prior efficacy or history of immune-related adverse events was not driving that thing. And even in patients who initially responded to prior ICI, that ICI-free interval, once resistance occurred, retreatment with Nivo also showed a limited efficacy only. So take-homes are, typical approach is generally chemotherapy till date, long treatment-free interval from immune checkpoint inhibitor, then rechallenge may be attempted. Though the treatment-free interval after ICI is not defined in the literature, but reasonable time period concluded in the consensus is at least 6 months. Oligoprogression, we do not know whether giving local therapy and continuing ICI versus changing to newer approaches would matter. And other investigational approaches like ramucirumab and pembro or cabozantinib plus minus atezo like discussed in the previous talks, would they be a good one over and above continuing ICI? What is the role of rebiopsy? How do we take the resistant mutations into picture? These are something which are still unanswered. Thank you.